managing an acute asthma exacerbation successfully and seeing a patient rapidly improve is very satisfying for doctors, and we regularly and often run into it very early in our careers. So let's go through this question and see how well we can manage an acute asthma exacerbation. 37-year-old has brittle asthma, comes to ED with an exacerbation. She's been started on 40 milligrams of pred 48 hours before, and the salmeterol fluticasone inhaler has been doubled, but that's not made much of a difference. Temperature is slightly raised, blood pressure is okay, she's slightly tachycardic, looks tired, there's a bilateral wheeze on auscultation. Her peak flows are 135, goes up to 180 after 30 minutes of back-to-back nebulizers. Her predicted peak flows are 510. Now, her oxygen saturation is 92%. She's also been given 200 milligrams of IV hydrocort. Looking at the blood, there's nothing interesting. White cells are slightly elevated. She's had an X-ray, and there's no sign of consolidation on the X-ray. Now, so what is the clinical picture here? Now, I always stress the importance of having the right clinical decision-making mindset when approaching MRCP questions. Now, this is an MRCP Part 2 question taken from MRCP Updates past paper questions. So, can we try and eliminate answers just using our clinical reasoning? So this is a very important tool to master for your MRCP exams. I'm going to put a pop-up video here on the screen where I go over 5 other questions using this clinical decision-making and clinical reasoning for elimination and demonstrating it in 5 questions. But let's try and do it here as well. So this is an acute asthma exacerbation. Peak flows are normally 510. Hers was 135, so that's less than 33%. So this is very severe. Even if we don't know the classification yet, we know that this is a very severe life-threatening asthma. She's also requiring oxygen. Okay, so this clinical picture here, so this is the clinical decision-making. What is the picture here? It's an asthma exacerbation. So we can use this clinical reasoning and eliminate choice B, IV comoxiclav, because we don't have an infection. There's no consolidation. Yes, the white cells are slightly raised and the temperature is slightly raised. This is classic MRCP. Because this is not the overall picture, and you need to know the overall picture. So B is eliminated. Now, from the other choices, IV ipratropium and IV salbutamol. Now, even if you don't know the acute exacerbation guidelines word for word, you've probably heard of nebulized ipratropium and salbutamol. Now, there's no need to give it IV. If anything, IV salbutamol is quite arrhythmogenic. So it's not safe to give it IV, and IV ipratropium is not given. So we can safely eliminate C and E. That leaves us with choice A and D. Do we give IV aminophylline, or do we give IV magnesium sulfate? So let's get into how to classify and manage acute asthma. Now, the British Thoracic Society, BTS, classified patients with acute asthma into moderate, severe, and life-threatening. Now, moderate is peak flows 50 to 75%. That's either of the predicted. If we don't know what's their best peak flows, there is a chart where you can put in the weight and the age, and it gives you the predicted weight, height, and age, and it gives you the predicted peak flows. Speech is normal, respirates are normal, pulse is less than 110. Severe, peak flows are 33 to 50%. Can't complete sentences, respirates are raised more than 25, tachycardic more than 110. Now, they might have some severe features. They don't need to have all of them. Okay? So if they have a few severe features, we can say this is a severe acute asthma exacerbation. Now, this is with the life-threatening. If they have one of the life-threatening features, we can say this is a life-threatening asthma exacerbation. Peak flow less than 33%, which our patient had. SATs less than 92%, with which our patient had. So our patient has two features of life-threatening asthma. So we can classify this as a life-threatening asthma exacerbation. Others are normal CO2. Now, the reason why the normal is in parentheses is that it's not really normal because patients with asthma exacerbations are hyperventilating. We would expect the CO2 to be low. So if the CO2 is normal, then that's high. That's considered a high CO2. Silent chest cyanosis, not having much respiratory effort, or if you don't hear good bilateral air entry, bradycardia, arrhythmia, hypotension, exhaustion, confusion, coma, so very life-threatening features. There's also a near-fatal asthma, where we would classify it as such if the CO2 is raised or if the patient is requiring mechanical ventilation and inflation pressures are raised. Now, carrying on, further assessment. When do you need to do an ABG in an asthma exacerbation? If they're requiring oxygen, you put them on 15 litres of oxygen and then you do an ABG. So chest x-ray is not recommended unless there's a life-threatening asthma. That's why our case had a chest x-ray. If we suspect pneumothorax, especially in patients that are smokers or cannabis users, or they're tall, thin, and seem like the typical spontaneous pneumothorax patients that have been on BiPAP, on an IV, we suspect pneumothorax. So if we suspect it, we should do a chest x-ray. And failure to respond to treatment. When do we admit patients with asthma? This is a common thing if you're a medical registrar, if you're a medical SHO, or if you're an F1 on your medical rotations, you run into this question. When should we admit our asthmatics? All life-threatening. Anyone with a life-threatening feature should be admitted. Anyone with severe acute asthma that don't respond to initial treatment should be admitted. Near-fatal asthma attacks, pregnant asthmatics, attack occurring during the night, or if they're already on steroids and they're still wheezy and having an asthma exacerbation. So the reason for night presentations is that usually asthmatics, if they have night symptoms, it classifies. If someone has more than one awakening at night a week, then that classifies as uncontrolled asthma. So it would mean that their asthma is uncontrolled. Now, I'd like to take a moment here to talk about MRCP updates. This MRCP question and the explanations are from MRCP Updates. You can subscribe using the link below, and you'll get a 10% exclusive discount. They have thousands of past paper questions with elaborate explanations and an online textbook ideal for visual learners. I personally used MRCP Updates for my Part 1 and Part 2 preparation. It's a great preparation resource, and I do recommend using it 3 to 6 months before your exam. If you're unsure how to start your preparation, I'll put 2 videos on the screen at the end of the video detailing what to do to prepare for your MRCP Part 1 and Part 2 step by step. Going back to our discussion of asthma, now we're going to talk about the management. How do you've confirmed this is a severe asthma or life-threatening asthma. Now, how do you treat them? First is oxygen. If they're hypoxemic, if the SpO2 is less than 94%, then you put them on oxygen on 15 litres via non-rebreather mask, and then you do an ABG. We said if your patient is hypoxemic, you do an ABG. We do this to make sure that the patient is not a CO2 retainer, because if they are a CO2 retainer, then we need to change our target saturations to 88 to 92%. Now, so we've given oxygen. Next, we need to bronchodilate. Now, we often do that with a SABA, with short-acting beta agonists, such as salbutamol. In patients without life-threatening features, you can give it as an inhaler, but often it's given in hospital. It's given as a nebulizer. So nebulized SABA is often recommended, especially in life-threatening or severe asthma attacks. So oxygen, SABA, next is steroids. Recommended is 40 to 50 milligrams of prednisolone orally for at least 5 days. Now, even in a severe exacerbation, you can still give it oral, because oral steroids has excellent bioavailability, and it's very comparable to IV hydrocortisone or IV steroids. So if the exception is if a patient is vomiting, if they're not very conscious, or if they're unable to swallow, then we can give it IV. or if you already have IV access and the patient is very unwell, you can give it IV. Now, ipratropium bromide, nebulized ipratropium bromide, is a muscarinic antagonist, and in patients who've had back-to-back SABA nebulizers, salbutamol nebulizers, and they're not responding, we could also nebulize with ipratropium. Now, when we say back-to-back salbutamol, we usually give one and then repeat it in 20 minutes, and then we can repeat another one in another 20 minutes. But if we give 2 salbutamol nebulizers and the patient is still not responding, then we can give some ipratropium. Now, this is where we turn into a problem. If the patient has not responded up to this point as our patient, then what do we do next? Now, next option is IV magnesium sulfate. Now, the BTS notes that evidence is mixed for the treatment, but it's often given in severe or life-threatening asthma. If there are any intensivists, please leave me a comment in the comment section. Tell me if you are a fan of magnesium sulfate, because I know that in intensivists in ITU love giving magnesium. But there is mixed evidence, but it's usually recommended. If the patient is not responding, then you give IV magnesium sulfate. Usual is 8 millimoles in 100 ml of saline, given over 20 minutes. Now, amino fill-in is the other choice, but this can only be given after discussion with senior respiratory teams, because they can have a lot of side effects. So if you've gone until IV magnesium sulfate and the patient is still not responding the way that you want, you should inform 2 people: the ITU team, the intensive care team, for a possible intubation, and your senior respiratory team. So going back to our question, what is the next step? The next step would be IV magnesium sulfate, because we haven't tried this yet. So IV magnesium sulfate and not IV aminophilin, which again has a lot of side effects and needs a discussion with a senior respiratory team. Now, patients who fail to respond require prompt ITU assessment. Now, this is very important. If you have a patient, these things take time. So if you have an exacerbation, you give a salbutamol, you give steroids, you put them on oxygen, and they're still desaturating and they're still very wheezy and they can't complete a sentence, then call your intensivist, your ITU team, straight away, so that they can come and assess the patient to see if they want to intubate right there and then, or you want to continue with the treatment. So you can give all of this treatment, your back-to-back nebulizers, your steroids, your oxygen, your ipratropium, your IV magnesium sulfate. But in the meantime, also get an intensivist to see your patient to see whether we would need to intubate and ventilate, and potentially if they're taken to ITU, they might be started on ECMO, and so it becomes a higher level of care. Now, criteria for discharge. When do you discharge patients? Very good and very good question, and it's a common clinical scenario. Usually, if they are on nebulizers, a rule of thumb is that once they stop being wheezy, you can stop the nebulizers, you can restart their regular inhalers. And one point I forgot to mention is that when you give steroids, always continue their inhaled steroid inhalers. So inhaled steroids can be given alongside oral or IV steroids. The only thing you stop is if you're giving nebulized salbutamol and ipratropium, then you need to stop the inhalers containing SABAs and ipratropium. Okay, but usually the rule of thumb is once they stop being wheezy or the wheeze improves, you stop the nebulizers and you put it as needed as a PRN basis, and you keep observing them for 12 to 24 hours. And if they don't require any nebulizers or any oxygen for that period, when they're back on their inhalers and they're off the nebulizers and oxygen, then they can be sent home. You need to make sure that inhaler technique is checked and recorded, and that their peak flows are 75% of their best or of their predicted. It's very important and very good practice to keep a peak flow monitor for all of your asthmatic patients that are admitted in the hospital. Alright guys, that was our acute asthma exacerbation video. If you like the content, please like the video, leave me a comment, and don't forget to subscribe to the channel for more content like this. See you next time.